Hi everyone, it's Renee again. In this voiceover, we're going to discuss visual disorders of the eye. This is an outline of the visual disorders we will be covering. Retinopathy of prematurity, visual acuity disorders, cataracts, glaucoma, macular degeneration, retinal detachment, and eye trauma. So we're going to start with retinopathy of prematurity. It occurs because the retina is not completely vascularized and is subject to stress and injury. This is commonly seen in premature babies and those with low birth weight. Vasoproliferation, which is an abnormal growth of vasculature, occurs when the tissue grows within the retina, and this is abnormal vascularization and associated with bleeding and fluid leakage, and it leads to scar tissue that pulls and distorts the retina and displaces the macula, causing retinal fold and can lead to retinal detachment. Again, this is usually found in infants before 29 weeks of gestation and 67% of babies that weigh less than 1251 grams. There are 5 stages, stage 4 being partial retinal detachment and stage 5 being complete retinal detachment. And stage 5 is the most severe. Long-term recovery really depends on the extent of damage. It can range from a full recovery to complete blindness, but 90% of neonates will recover with minimal or no loss or blindness. There are several risk factors associated with retinopathy of prematurity. The risk factors include prematurity and low birth weight, prolonged exposure to high levels of oxygen, and duration of mechanical ventilation. There are other risk factors, but these are the primary risk factors. To decrease the risk of retinopathy of prematurity, we can use continuous pulse oximetry during resuscitation measures, the careful use of oxygen during procedures, starting with the use of room air and working up using an oxygen blender to keep the SATs between 87 and 94%, and avoiding bright lights that will stress the already fragile eye vessels. So managing retinopathy of prematurity, a pediatric ophthalmologist will see neonates 4 to 6 weeks after birth for any baby born before 30 weeks or weighing less than 1,500 grams. Babies born weighing 1,500 to 2,000 grams and having medical complications at birth should also be examined. The focus of treatment is to reduce the risk of blindness, and treatment can involve corrective lenses and eye surgery. So we did discuss the visual acuity disorders a little bit in the visual assessment voiceover. These are myopia, hyperopia, astigmatism, and presbyopia. These errors occur when the bending of light rays by the cornea and lens don't focus an image correctly on the retina. These disorders affect a third of people over the age of 40. Visual acuity disorders can be managed with corrective lenses or surgery. Surgical management may include radiokeratotomy, which is a procedure in which tiny incisions are made in the cornea, causing it to flatten and reduce the refraction disorder. Photorefractive keratotomy, or PRK, involves removing a portion of the cornea with a laser to change its shape and therefore modify the refractive error. Laser-assisted in situ keratomileusis, or LASIK, involves the use of a laser or instrument called a microkeratome to create a thin circular flap in the cornea. Laser thermal keratoplasty, or LTK, uses a laser to reshape the cornea. Conductive keratoplasty uses radio frequency energy and does not remove any corneal tissue. A cataract is an opacity in the lens of an eye that impairs vision. Cataracts occur as a result of alterations in lens proteins as a person ages. The lens will gradually become cloudy, secondary to chemical changes. Some risk factors for cataracts include UV light exposure, advanced age, family history of cataracts, or family history of diabetes or other chronic health problems, obesity, elevated blood pressure, smoking and alcohol use, along with environmental factors. These are all other risk factors for cataracts. Some of the signs or clinical manifestations of cataracts include blurry vision, clouded vision, or vision that is dimmed. A client with cataracts may also have difficulty seeing at night. They can have sensitivities to light and glare. They may also see a halo around objects. They can have issues with color fading or have double vision in a single eye. They may have nystagmus, which is involuntary eye movement, or strabismus, which is when the eyes don't look in the same direction at the same time, or an absence of the red reflex. Congenital cataracts in newborns are actually diagnosed by this absence of the red reflex. The most effective treatment of cataracts is surgical removal of the lens. It is usually done via one of two surgical methods: phacoemulsification or extracapsular or intracapsular cataract extraction. These are the two most common operations in the U.S. for management of cataracts and for people over the age of 65. Some nursing implications for caring with a patient having cataract surgery include implementing safety measures, administering eye drops pre-procedure to dilate the eyes for better visualization, elevating the head of the bed 30 to 45 degrees, and ensuring the client is positioned on their back or on the non-operative side, and maintaining the eye patch as directed by the provider. Some post-operative teaching will include decreasing risk factors, wearing protective glasses, especially in the presence of sunlight, which is a known factor in promoting cataract formation. There should be a discussion on safety concerns, especially in the client returning to driving. The client should be made aware of the importance of follow-up appointments so the condition can be monitored closely for changes. Clients should also know that they should not expect their best vision until 4 to 6 weeks after surgery. Immediate post-op care after returning home include refraining from rubbing or applying pressure to the eye. The client should avoid anything that will increase intraocular pressure, such as sneezing, coughing, bending over, vomiting, or lifting heavy objects over 5 pounds. We need to prevent constipation as well because straining can increase intraocular pressure. The client should avoid eye strain and follow the provider's orders for eye dressings and use an eye shield at bedtime. To prevent infection, we're going to encourage good hand washing. They should always wipe excess tearing from the inner to the outer canthus with a clean, soft tissue. Most importantly, you want to educate the client to contact the provider immediately if they have any severe pain, visual changes, or an increase in discharge from the eye. So now we're moving on to glaucoma. Glaucoma is a group of eye conditions where increased ocular pressure, or IOP, and damage to the optic nerve leads to vision loss and potentially blindness. Increased IOP can be caused by inadequate draining or overproduction of the aqueous humor. Normal range of IOP is 10 to 21 millimeters of mercury. Diagnosing glaucoma early is important for minimizing or preventing visual loss. There are 5 types of glaucoma, but there are 2 primary types, which are primary open-angle glaucoma and angle closure glaucoma. Primary open-angle glaucoma is the most common form of the disease, and it affects approximately 3 million Americans. The aqueous humor outflow is decreased due to blockages in the eye drainage system, which causes pressure to build up. With angle closure glaucoma, also known as acute glaucoma, or narrow angle glaucoma, there is a rapid rise in eye pressure and immediate treatment is required. This is a relatively rare form of glaucoma. Normal tension glaucoma, also known as low tension glaucoma or normal pressure glaucoma. This is where the pressure will usually be in that 10 to 21 millimeter of mercury range, but there is still damage being done. Possible causes include a fragile optic nerve or a decrease in blood flow to the nerve. Secondary glaucoma usually results from an eye injury, inflammation, tumor, or advanced cases of cataracts or diabetes. Pediatric glaucoma consists of congenital glaucoma, which is diagnosed during the first year of life. The clinical manifestations will vary depending on the type of glaucoma. In primary open-angle glaucoma, clients usually experience headaches, mild eye pain, loss of peripheral vision, decreased accommodation, and halos are often seen around lights. The intraocular pressure is usually elevated between 22 and 32 millimeters of mercury. There is a gradual loss of peripheral vision, usually in both eyes, and tunnel vision in advanced stages. Acute angle glaucoma is usually characterized by severe eye pain, nausea and vomiting, and sudden onset of visual disturbances, often in low light. They also have blurred vision or halo vision and reddening of the eye, and the pressure is usually 30 millimeters of mercury or higher. The best prevention for glaucoma is regular eye exams. At these exams, clients can be assessed for increased intraocular pressure. They can be questioned for any changes in vision or light sensitivity or any aching or discomfort around the eyes. The priority intervention for treating glaucoma is medication therapy, especially in the earliest stages. The medications can cause the eye to produce less aqueous humor, and other medications can help drain the fluid in the eye, thereby decreasing the pressure. Surgery is used to treat glaucoma if medications are not effective in treating the disease. Laser trabeculoplasty is used in treating open-angle glaucoma. Filtering surgery is usually done in a hospital or outpatient surgery center under local anesthesia. Drainage implants are used most commonly with secondary glaucoma or pediatric glaucoma. Glaucoma medications and eye drops. So one of the most important roles of the nurse in the management of glaucoma is educating the client about the various medications and eye drops they may need to use, as well as proper installation of the eye drops. During our class case study, we're going to take a closer look at the medications used to treat glaucoma, but on this slide it does show you some of those and the instructions for instilling eye drops. Moving on to macular degeneration. Macular degeneration is the most common age-related eye disease affecting the macula, the part of the eye that is responsible for central vision, and it allows for vision in fine detail. Macular degeneration typically causes no pain. Gradually, it destroys the sharp central vision. There are modifiable risk factors of macular degeneration, including high blood pressure, high cholesterol, obesity, smoking, and a decrease in zinc blood levels. Some non-modifiable risk factors for macular degeneration include age, family history, gender, and race. There are two forms of macular degeneration. There's dry macular degeneration and wet macular degeneration. Dry macular degeneration is the most common form of macular degeneration, and it occurs when the light-sensitive cells in the macula slowly start to break down. This results in a gradual blurring of the central vision. There are three phases of dry macular degeneration: early, intermediate, and advanced. One of the most common early indications of macular degeneration are drusen bodies, which are yellow fat deposits that are located under the retina and are usually found in people over the age of 60. One of the key clinical manifestations is the client will have difficulty recognizing faces. Wet macular degeneration occurs when abnormal blood vessels located behind the retina start to grow under the macula. This results in a quick loss of central vision and is also known as advanced macular degeneration. In terms of treatment, for dry macular degeneration, no form of treatment can prevent the vision loss. Laser surgery and photodynamic therapy and injections directly into the eye can be tried, but there's no cure for macular degeneration, and despite treatment, the disease and vision loss may continue to progress. For wet macular degeneration, there are two therapies: photodynamic therapy and antivascular endothelial growth factor therapy. Photodynamic therapy is a specialized laser treatment that uses stimulation or activation of photosensitive dye by exposure to the light of known wavelengths that results in closure of new vessels. Antivascular endothelial growth factor therapy uses injections directly into the eye. The medication blocks the effect of the growth factor. It helps slow the progression of vision loss and in some cases can improve sight. Laser surgery uses a laser light beam to destroy the fragile, leaky blood vessels that are accumulating behind the macula and can be attempted for wet macular degeneration. Only a small percentage of patients can be treated with this surgery, and the risk of developing new blood vessels after the laser treatment is high, and vision loss may progress despite repeated treatments in some individuals. So now we're going to discuss retinal detachment. Patients presenting with retinal detachment typically complain of floaters in their eyes, accompanied by flashing lights. As detachment progresses, visual loss increases to present what looks like a curtain over the visual field. Risk factors for retinal detachment include patients who suffer from extreme myopic refraction disturbances, if they have a history of retinal detachment in another eye, or if they have a family history of retinal detachment. Patients who have had cataract surgery or have suffered eye injuries, if they have any other eye diseases or disorders, or if they have a presence of systemic diseases, these can all be risk factors for retinal detachment. Separation of the retina occurs by three basic mechanisms. Rhabdomatogenous separation is the most common form of retinal detachment and occurs when a tear or break in the retina allows fluid to move under the retina and separate it from the pigmented cell layer that nourishes the retina. Tractional detachment is the least common type of detachment and occurs when scar tissue on the retina surface contracts and causes the retina to separate. Exudative detachment is usually caused by retinal disease, including inflammatory disorders and injury or trauma to the eye. The most common and successful treatments for retinal detachments include laser photocoagulation, panretinal photocoagulation, cryopexy, pneumatic retinopexy, scleral buckling, and vitrectomy. Okay, so lastly, we're going to talk about eye trauma and visual loss related to blunt or penetrating trauma. 35% of these cases are affecting clients under the age of 17. The most common risk factors include male gender, sports participation, occupation, and being in the 18 to 45 range for your age group, and consumption of alcohol. Blunt trauma, which is the most common of the two, occurs when the eye is struck with a finger, fist, or some solid object, and it may yield an injury where bleeding occurs between the cornea and the iris. Penetrating trauma refers to injuries in which the eye is pierced by a sharp object, such as a knife or a piece of metal. And this is the type of injury that is usually due to a lack of eye protection. Clinical manifestations are going to vary widely depending on the type of trauma and the extent of injury, but can include eye pain, edema, scleral discoloration, bruising, blurred double and loss of vision, and excessive tearing. Following up with an eye care specialist is essential, and this is usually done on a frequent basis because close observation of an eye injury is very important to monitoring for proper healing and to prevent further damage, including hemorrhage. Patients who present with a penetrating object in the eye should never have that object removed by anyone other than an eye care professional. Management of eye trauma will include rest, eye patching, and special eye drops, or in the case of a penetrating trauma, it could be antibiotic eye drops. Okay, so that concludes our voiceover on visual disorders of the eye. If you have any questions, feel free to reach out to me. We are now going to move on to the voiceover for hearing impairment.